And so we're going to get a little personal, more personal than we have been. Before your diagnosis, what did you do to make a living? How did you make money? What did you do? How did you support yourself?
Oh, I was selling the campus.
Okay.
I was in school. I was selling the campus. Offering Ghana,
Okay.
paying the school fee.
And when he was on the campus, what campus?
Cars,
And then with your illness, being sick, doing the treatment, how did that affect? You're a single mother. How did that affect your money, your finances?
they fed me bad because when I was sick, he didn't want. He went for referee training, LFA, LFA training in Kakatan. So when he graduated from there, when he's studying piano, banga, Kakatan, ele transportation, he will take me and dissolve me. For me to eat before he go.
Did you have help from your community?
No.
No.
And then my church sister,
The same church sister,
one mother,
another one, help you.
three, they didn't want to help me.
Dr. Superwood, is that the reality of most of your patients?
Unfortunately, yes. And because of this, we diagnose a lot of patients, but we get to treat only few. Because earlier in the discussion, I mentioned that patients don't have insurance, so they have to pay for everything out of pocket. And that starts from the diagnostics, getting the labs done, the various, lab works done. It's really expensive. So by the time they manage to get to the final diagnosis, financially they're already exhausted. So sadly, by the time you tell them this is what you have, they have no monies left to get treated. So because of that, we diagnose a lot of patients, but we treat a very few because there's no money to come back to start the treatment. From my experience over the last year and couple of months, I can tell you that on average, a cancer patient in Liberia spends around a minimum of 500 US dollars every 3 weeks.
Wow.
Yes. So imagine that you have to spend at least 500 US dollars every 3 weeks. How many persons can even afford that? So it's frustrating because there's no money. You have in a society where some people are living on less than $1 a day. So it's a problem. There's no money. So yeah, it's a story that I encounter every day or every other day that I diagnose a cancer patient. Yeah.
Dr. Cooper, what would you say would be the biggest challenge in treating the patients besides the financial part that she just mentioned?
I cannot understate the financial part, to be honest. The biggest part, apart from the financial part, is the other financial part. But let's say all finances being provided, the biggest part is education and accepting the diagnosis and accepting treatment. I mentioned that my clinic has worked with Alpha Kappa Alpha since 2021, and then also with Zeta Phi Beta, with some other organizations as well for screening. I mentioned that we started off by doing the mammogram, which is a special breast x-ray, just to diagnose. Later on, we added on that we need to treat. Later on, we realized that, listen, we need to have some type of facility where everybody can get their treatment together. The biggest problem, even when we raised the money for the mammograms, the breast scans, the biggest problem we had is people who were told they were positive. Actually, even when we started the free treatment program to get people to show up to take the treatment, the fear. The next thing we know, she went she went Sino, she went River Cess, she went home to vote. 6 months now, she can't come back from voting. Oh, has somebody sick? Mama, yourself sick. Yourself sick. If you don't take care of yourself, you will not take care. You'll not be here to take care of your children. And that's how, even in the clinic, we chase, we call, please come in. And the whole time I'm sitting in my office and I know this person is getting worse. There are some patients that from the time we diagnosed them where they were, after 3 months, I question myself, is this person still living? And they say, oh, they went to their hometown. What that means, they've gone to sick bush. And that's when my own fear can start. Because what is happening to that woman? I understand that people are so afraid. They don't want to hear that it's cancer. They want somebody to tell them it's something else. So they want to go and let a reverend tell them that it's spiritual, because spiritual means I can just pray and it will go away. I don't have to do the difficult work. I don't have to do a surgery. I don't have to think about the fact that my medicine is $500 or $1,000 a month, $1,500 a month, scans another $500 every few months. I don't have to think about that problem. I can just pray. That sounds easier. It sounds like something I can manage. It sounds like something I know how to do. This other one, because the even very educated women, we ask them to come and do breast screening. They say, I don't want to know. When you go to a doctor, they put all kind of big thing on you. So I don't want to know. That's what they will say. I don't want to know. So for me, aside from the financial side, the education and the access, that's why I'm so grateful that Florence is here today to explain to people that she has done it. It can be done, and you can finish your treatment, and you can be sitting here smiling with your family, living with your family, but you have to do it. You have to do it. Those who ran away are not here today. Those who ran to the sick bush, those who denied it, they went all around, they just wanted to pray, they were not here. And don't get me wrong, I'm a woman of faith, but I thank God for the education he gave me, the education he gave Dr. Superwood, the education he gave to those pharmacists that created the drugs. Thank God for him showing human beings how to solve our problems. I heard somebody say that if you are in a boat, the boat is drowning. Somebody gives you a life vest. Will you say, no, I don't want a life vest. I will be in the water, be praying. God will save me. But God is sending you a life vest. No, I will stay in the water. God will save me. No, God is sending you a way to be saved. You have to take it. You have to take it. So outside of the financial, the accepting that this is the way God has given you to save your life, that is a difficult part for people.
Dr. Jala, I would ask the same question. What has been the biggest challenge that you've seen?
Well, the biggest challenge, besides all what have already been said, is we need to move to the churches and convince the pastors, wherever places that people go to for refuge. We need to go to these people and help to convince them that not everything that you see is witchcraft. Because this is the biggest thing. We always think that somebody threw it on us or somebody put this cancer on you. If we can work with the churches or with the people that really are influential in people's lives and be able to make sure that they can encourage people that the first step is, yes, while you're praying, let the person be seeking the care in the hospital. I think we'll win a lot more battles, while we look for the finances and look for the other things. But I think we need to go back, have this conversation with leaders that are influencing people's lives. And maybe it will help us to save a lot of those lives. Because right now, as we speak, if you go to a couple of churches, you will see people laying on the cold floor or on altars or drinking multiple bottles of prophetic water, they call it, and they're not getting better. So this is our challenge.
Okay. So I want to ask you, Florence, I think is it a psychosocial group that is held at your facility? And so you guys go and you talk about what's going on, your feelings. What would you tell a woman that was you at the early stages of a woman being told you have cancer? what would you tell that person?
I would tell them, when you go to the hospital, when you tell you that you got cancer, you should accept it. Accept what the doctor say. Don't mind that your breast, you should be feeling pain in your breast, or you are not in your breast, so you are sore. Then because of that, you want to take out the breast, and you want that. I don't want you to do that. I want for you to accept it and take out the breast and live a longer life that God will give you. So today, I sit here, tell them, accept what the doctor will say when you go there for treatment.
Thank you. So we're going to end now, and I'll just have all three doctors tell me in your own words what the future holds for cancer treatment in Liberia, or what you envision, what you want to see in the future. It could be either. We'll start with Dr. Jala.
I'm sure all of us will say the same thing. Or, well, for me, more advocacy. I think we need to, we're talking to people in Montserrat, but I think we should reach out to all of the counties and make sure that every woman have either some type of breast examination, even if she can't have a mammogram, but she should have some type of breast examination, either herself plus or minus her doctor, and that we should have a pathway where if we find a breast that has a lump or fungating breast or whatever type of breast we find, that people know where to go. Because I think we're missing out on people because they don't know where to go. So they find themselves in different directions. So having a pathway for the treatment, having a chemotherapy center and having a radiotherapy center, that way our people don't go to Ghana and die or come back and die, because that's what we see happening now.
Yeah, so I would like to start from where our mother, Dr. Chala, stopped. She has been championing breast cancer for over 15, 20 years in Liberia. We applaud her. You know, she passed the mantle on to an extent, so we have to pick it up and run with it. So starting from where she stopped about advocacy, we, like she said, we have to reach out to people more. We have to educate our population more about breast cancer and every other type of cancer. But then also, we also need to have, like she said, also a referral pathway, or fixed referral pathway, because diagnosing someone or telling someone that you have to do this when this is happening to you is one thing. How to go about doing it is another thing. So we have to have a referral pathway. 5 years ago, 10 years ago, Liberia did not have any specialists in the field. Today we can boast of one medical oncologist. Today we can boast of one pediatric oncologist. Today we can boast of 3 gynae oncologists in Liberia. So the number might sound small, but we have at least 5 doctors that are taking care of cancer patients in Liberia now. So that is one aspect of the training of more human resource. The other part is having a center for the patients to go. Dr. Jala mentioned that, post-war Liberia, there was a chemo center in JFK, in the maternity center, that was shut down. So we picked up the mantle and we started running with it again, and we have been trying to get things organized. So fortunately, by the end of this month, hopefully JFK will be reopening a chemo center where people, at least cancer patients, will have a place to go and receive the treatment. So that's the other thing. I know there are negotiations ongoing for a radiation, and what have you, but it's always we always have to start from somewhere. Yes, so we are working on that to have the chemo unit reopen in JFK by the end of this month, hopefully. And we will go back to the table and negotiate again, renegotiate, or start from where she started with the radiation, to push further for more radiation, and to just encourage people more, that this is it. And you will be surprised that the education is not only for the patients and the general, it's even for some of our colleagues, for some doctors as well. Because if you look at Florence's story, she went to 2 facilities before getting to JFK. Some other people's stories are even worse than that. They bounce all around in the system, and by the time they get to where they should be, it's already very late. So education is not just for our patients, also for doctors as well. You know, it's for healthcare workers, middle healthcare workers, that if you have a patient that is like this, please follow the patient. We have to go back to the communities, to the mosques, to the churches, to encourage the pastors that please talk to your members that, you know, we all are Christians, you know, we all are Muslims, we belong to a certain faith. But I don't think that whatever holy book that we believe in stops us from going to get treated. So encourage your patients, encourage your members to go seek the medical aspect while they are praying. Because this is something, this is a serious issue that we are facing as health care workers in Liberia. Yes, we are battling patients leaving the hospital and going to the sick bush, or going to lay down in the church, or going to lay down in the mosques and pray. And praying it away is not going to just make it disappear. You have to pray and seek treatment at the same time. So
Pray and do.
yes, talk and do. Pray and do. Yeah, because in the same Bible says, faith without work is their faith. So you have the faith, you work on it as well, work, and then God can intervene. So we have to go back and, you know, engage the public more and just, you know, see what we can do from there. But hopefully, we hope that, you know, going forward, like I said, 10 years ago, Liberia did not have an oncologist. Now Liberia has 5 oncologists in different fields. We have someone that can care for children cancer. We have 3 that can care for women cancers. We have medical oncologists. So hopefully, we will encourage more education, more, you know, training of staff and what have you, and engage the public more, because the first step is having the public aware that cancer exists and you need to look out for these signs and symptoms. So yeah, that's it.
And Dr. Cooper, will end with you.
Okay, thank you. I have 2 words. You asked, where do we see cancer care going? I have 2 words. 1 is collaboration and 2 is sustainability. Dr. Jala mentioned all the elements: having radiotherapy, having the chemotherapy, having the surgeons, having all the elements. That is the collaboration element. You know, Dr. Jala and I have worked on several things before. So hearing all the work that she is pushing for, we are very open for collaboration. We want to make sure that we are collaborating with everybody who is working in the space, knows who else is working in the space and what they are doing, so we don't bounce patients left to right to right. You need this, we know exactly who has it. You need that, we know exactly who has it. So that is one element of collaboration. Dr. Superwood also mentioned the wonderful progress they're making at JFK to have the infusion unit. Collaboration is also key. Why? Because infusion unit is one thing, chemotherapy treatment is one thing. Having the full center where you can do your mammogram, you can do your CT scan, you can do your surgery, you can do your chemotherapy is another thing. So we need to work together to make sure that we get it from just the treatment unit to everything that it needs to be. And then sustainability. Like I said, we cannot overemphasize the financial part of it, because we can build the whole unit. It can be beautiful. And 5 people in a year will be able to afford to go there if we don't do something about sustainability. One of the, I will not say easy, but one of the areas where we have a plan that has worked for other types of medications is, for other types of diseases, is the medication area. One thing I know is very close to Dr. Jala's heart is this concept of revolving drug fund. It is something where, let's say the government or some of our partners buys the first amount of drugs. Patients who are using those drugs, the ones who can afford to pay something so that the drugs don't just get used and there's nothing left. When you put something in, the system uses that money to buy more, so the next person that comes will get it. It's not to say we are trying to sell it at high prices, but those who can afford to pay something, pay into it to keep the drug supply there so those who need it can have it. Now, that is one element. It's not going to be enough, because when we talk about radiotherapy, you cannot rebuy the new radiotherapy, right? So eventually we are going to have a payment system that will be sustainable to support this care. Nowhere in the world,
It's cancer.
nowhere in the world is cancer treatment cheap. But nowhere in the world do they reasonably expect a cancer patient who already cannot work because of their sickness to be able to pay this money from their own pocket. It's not done.
Only when you go to Ghana.
It's not done. Nowhere in the, I would say, the more organized health systems is it done. We have to find a way to take care of our people.